Not only because of his passion and ability for teaching, but also for his generosity and always being willing to share his knowledge and his wisdom with everybody. About a year ago, he had a single-authored review article in the New England Journal on iron deficiency and other microcytic anemias, and so I asked him to come and speak to us today about updating us on iron deficiency.
Great.
Tom?
Thank you very much. Thank you. It's always a pleasure to come here, and I'm pleased today to be speaking about one of my favorite subjects, iron deficiency. So again, I'm Tom DeLoughery from OHSU. I have no conflicts of interest. So what am I going to talk about today? Really two key concepts. One, iron is good. And secondly, we'll talk a bit about iron deficiency, diagnosis, and management of this. So unfortunately, to understand and make some key points, we have to learn a little bit about iron metabolism. I know it's a dreadful thing, especially at 8 o'clock in the morning, but I think some of this will help illustrate some key concepts. One is we absorb iron outside the stomach, mainly the duodenum and jejunum. There's a very specific iron receptor, and then the iron is exported or it's carried around the blood by transferrin. Now, there's an interesting way the iron is absorbed by the enterocyte, and then a protein called ferroportin, one of my favorite named proteins, ferroportin, the port of blood, port of iron, shoots it out into the blood where it's then taken up by transferrin and delivered to red cells and stored in the liver. And what's really interesting is we have grams of iron, but actually our body is so good at conserving iron that we only need to absorb a little bit every day. So, you know, we take in maybe a milligram or two a day we absorb. It's transported by transferrin, preferentially delivered to the developing red cell. When we're done with it, it's put into storage, and then we recycle it. Now, this is a very efficient process, but we know sometimes iron absorption can go haywire. And actually, one of the biggest diseases where it goes haywire is what we call the so-called anemia chronic disease. I used to always joke that we kind of always put in air quotes, but it's actually a real disease. You know, it's not just something hematologists make up when we can't figure out why somebody's anemic. And what happens is anemia chronic disease, we don't absorb iron. Iron is preferentially stored. It's not in the circulation. It's not delivered to the red cells. And what's been interesting is we understand now the basic molecular mechanism of this. And I think this will be, over the next few years, sort of an interesting developing story. There's a protein called hepcidin, which is an acute phase reactant. And this actually turns out to be another controller of iron regulation because it blocks iron absorption and it blocks release iron from stores. So if I go and get tuberculosis and become anemic, it's because I'm making too much hepcidin, I can't absorb iron, iron's not being delivered to developing red cell, and I become anemic. And what's also interesting is that it actually controls our daily intake of iron. So if I took an iron pill this morning, my iron level would shoot up, but my body then generates hepcidin, so I don't absorb any more iron for a period of time. As we'll talk about later, this actually has implications even for management of iron deficiency. And so what hepcidin does is actually destroy ferroportin. So when you have a lot of hepcidin, your gut absorbs iron but can't deliver it to the bloodstream, and your liver stores iron but can't deliver it to the red cell. And so we're kind of learning more about this protein. Molecularly, it's actually been very difficult to make antibodies to it, because this would almost be really great. You know, if we had a positive test for anemia chronic disease, you know, yes, Mr. Schmidlap, you're anemic because your hepcidin level is really high. And people are still working on that. Also, there's a lot of interest now in making hepcidin blockers to treat the anemia chronic disease, and a few of these are going to be starting to see in clinical trials. So kind of turned out to be a very key thing, and thing we'll talk about a little bit later, because it plays a key role in how we treat iron deficiency. So again, hepcidin is the master regulator of the anemia chronic disease here. So iron deficiency. Iron deficiency is very common, and as I'll make the case for, is treatable. Now, there's really, to me, three types of iron deficiency. And one of the messages of the talk is that iron does a lot more than just making you anemic. So there's what I call statistical iron deficiency. It's how the labs determine iron deficiency. They march 100 medical students to the lab. They measure ferritins or some other indices. And they use, whatever, like under 3 standard deviations to call people iron deficient. As we'll talk about, especially for older people and women, that is very unrealistic. And so what we're going to focus on in this part of the talk is what I call physiologic iron deficiency, effects of iron above and beyond just the blood. Now, there's also what I call pharmacological iron deficiency. And many of our nephrology colleagues are not happy unless the ferritin's expressed in exponential notation and because it's so high. And we're not going to talk about that. So iron's really very important. Iron is every cell of your body. It's important in a variety of enzyme systems. Muscle is the greatest second user of iron, like for myoglobin, oxygen carrier in the muscle. Brain iron is very important, and what we're really realizing now is iron deficiency is important above and beyond just being anemic. So for example, over 10 years ago, there was a study, a double-blind randomized trial of 144 women in Britain with fatigue. They went to their generalist and just said, I am tired. And they were randomized to placebo versus iron pills. And the endpoint was a very reliable visual analog fatigue scale. I am this tired. This was women 18 to 55. Anemia was exclusion criteria. What's interesting is they didn't exclude women with normal ferritins, but they did measure the ferritin. Interestingly, 85% of these women had ferritins over 50, 51%, over half had ferritins under 20. And what's interesting is the women responded very well to the iron, and women who had ferritins under 50 had the most robust response. Now, a few years later, this study was repeated with IV iron using a fatigue score. And what we saw overall that the fatigue improved, there was decreased fatigue, and especially in women with very low ferritins, under 15, or with low iron saturations, this was statistically significant. Finally, a couple of years ago, the Canadians repeated the oral study, given that's a lot easier to do. Again, not anemic, low iron levels, ferritins under 50. And again, they discovered that fatigue scores considerably improved. So what these studies really showed is that non-anemic iron deficiency, really at ferritin levels that we commonly call normal, actually were associated with symptomatology, and in a blinded, randomized fashion, iron truly improves symptoms. So it's something I think we got to think about, because we don't think about ferritins of 30 being abnormal, when in fact these studies would suggest they are. So we have 2 randomized trials of oral iron showing benefits with ferritin under 50, 1 randomized trial of aggressive IV iron with very low ferritins or low sats. And I think this is something I see a lot in my practice, and I think we need to consider if somebody's complaining of fatigue. Even our labs will say ferritins of 40, 45 are normal. There may be some benefit of iron therapy. Now, what about cognition? There's been a lot of studies on this because brain iron is very important. And there was a study of 81 women aged 13 to 18, teenagers, very low ferritins, again, not anemic, were randomized to iron versus placebo. And at the end of 8 weeks, the ferritin went up. And the analysis showed that the iron group had improved learning and improved memory. And just recently, there's been a pilot study of cognition, again showing treating iron deficiency, non-anemic iron deficiency, improved cognition. So again, I think this is another factor we see. And recently, there's been a study, a meta-analysis of 32 studies, about 7,000 kids, showing iron supplementation worked. It improved global cognition. If children were anemic, improved their IQ score, getting them non-anemic, height, weight. And again, most of these studies were done in low and middle income settings. But again, I think showing the role that iron plays above and beyond just helping to make the blood. Another thing that I've been particularly interested in, I think is an area of interest to a lot of us being active, is athletes. If you actually look, 33 to 80% of women athletes and 10 to 17% of male athletes are iron deficient. And this really affects a lot of things. It affects maximal exercise ability, endurance, strength. It actually affects cold tolerance. Your cells need to be iron replete for thyroid to work. So I always wonder how many marriages would be saved if everybody was iron replete in the United States and we weren't arguing about blankets and windows and things like that. So an example of one of these studies was done by Peter Barsch in Germany a few years ago, where he took really good athletes and randomized them. They all had low ferritins, but none were anemic. And he randomized them placebo versus iron pills. And what he showed is that the ferritin increased. There was no change in the blood counts. And again, especially in athletics, that's a major confounder. But the maximal exercise ability, the VO2 max, increased by 2%, which again, for an elite athlete, is a very major increase. And they could run, they had increased time to exhaustion. More recently in Australia, again, they took elite athletes with low ferritins or lowish ferritins and low SATs, again, randomized them to iron and found improved VO2 max, improved endurance, and the best results, again, being seen with aggressive iron repletion. And why is that? Well, it's kind of interesting. As I always like to say, blood is the most important organ. And as you become iron deficient, your body strips iron out of less essential organs like your muscle, your brain, to help the body continue to make blood. And this is a study that showed that actually giving EPO decreased the ferritin from 75 to 36%, but most of the iron was actually mobilized out of the muscle. So the iron stores, especially your muscle and other places, lose iron first before you actually become anemic. So I think why we see even relatively modest iron deficiency without anemia causing these symptoms is that the body is stripping iron out of the muscle, out of the brain, to help continue to supply the blood with iron. Now, why do athletes have low iron stores? Well, urine sweat losses are pretty negligible. There's a little bit of loss, but most of it actually seems to be increased gastrointestinal blood loss. There was a very strange study where 22 marathoners, actually their stool guaiaced after a marathon. Now, I've run marathons in the past, and I can't imagine finishing and seeing some guy with, a latex glove and some KY jelly greeting me. It's like, where's my medal? Where's the Gatorade? But actually a very high number of people with GI blood. There was also another interesting study where actually they had a group of elite athletes and basically fed them radioactive hamburgers for a while, and then actually Geiger counted their stool every day to see how much blood loss was there. Again, another kind of strange study. But what this showed is that with really running aggressive exercise, the blood loss went up by 1.5 mils per day on average, increasing with training. And if you actually look, with longer runs, there's increased blood loss. With races, there's increased blood loss. So a lot of these athletes, it appear that the GI tract is a major source of blood loss. Now, why is that? Well, a lot of it's probably gastritis. Maybe use of non-steroidals, stomach upset's pretty common. So that could be it. I don't particularly buy this theory of jarring of the bowel, but I just kind of like the image of it, like your colon slapping your spleen and, things are kind of shaking around. And I think whoever came up with this didn't have a great understanding of anatomy, but that's kind of an interesting theory. Maybe an element of ischemia, blood is shunted away from the gut when you run. Although it's interesting to actually see this iron loss both in swimmers and skaters. So again, it's maybe more complex than we think. But certainly GI blood loss is probably the major issue. Now there's other sources of iron loss. There is an element of hemolysis. Again, we think of foot strike, Tom running with his crummy shoes because he's too cheap to buy any, this morning. And so that's a very common thing. But what's interesting is, again, you see this in swimmers, in ice skaters, and some people think it may be muscle contraction. Now, again, I think that may be kind of vain, oh, my muscles are so strong, they're crushing my red cells. But it is interesting that actually increased red cell turnover is seen very frequently in athletes. Finally, our friend hepcidin plays a role. Training, especially aggressive training, induces a state of inflammation and actually can show increased inflammatory markers, increased levels of hepcidin in people who run and train, and this blocks iron absorption. So again, now we think athletes kind of get from both ways. Increased blood loss, they can't absorb, and it's probably not surprising a lot of them are iron deficient. So low iron, even without anemia, truly affects performance, probably due to decreased muscle stores. And I'm really aggressive in screening any one of my patients who are athletic, especially if they're women, and certainly if they're complaining of symptoms. And we now have more and more data that we can see improvements in performance in treating non-anemic iron deficiency. So There's also other things low iron does besides making people anemic. Again, our neurologist friends are very familiar with restless leg syndrome. We see this with low ferritins, especially ferritins even under 100, probably due to loss of CNS iron. I've always kind of find it puzzling that when I get authorization or recommendations to give iron, apparently people are supposed to fail all these very expensive drugs first before getting iron pills for restless legs. And I'm like, I wonder who wrote the guidelines. Anyway. Pica is very common, we don't understand, and especially in the Northwest, it's mainly iron deficient women getting cravings for ice. And I knew a physician once who would always want to chew ice, was floridly iron deficient. This is geographically different. In the South, it's actually eating clay, eating food. You know, it's like, Mama's eating dirt again. And, you know, why this is, we don't understand. Alopecia also can be seen, especially in women. Repleting my iron didn't help, but this is something else that can be there. So I think iron deficiency is important. Again, you know, obviously we're familiar with causing anemic, but I think there's clear evidence that iron deficiency causes issues with vitality, exercise performance, thinking, restless leg syndrome, hair growth. And again, since every cell in the body depends on iron, I think we're now finding more and more issues with iron deficiency and the issues that it causes. So how do we detect iron deficiency? Well, again, in a lot of labs, the laboratory values are arbitrary and don't reflect physiology. Especially ranges of normal, I think, are unrealistic for women and for older patients. Now, there's no physiologic reason why women should have a different range of normal ferritin. You know, do women need different iron stores? No, it's because women are mostly iron deficient. 85% of 20-year-old men have ferritins over 50. Only 25% of 20-year-old women do. And again, as I notice, is often, I think, overlooked cause of fatigue or other symptoms. If we say somebody, oh, you have a ferritin of 13, that's normal because the lab says so, we're missing something there. And all this is simply because women require more iron. On average, men require 1 milligram of iron a day. On average, women require about 2 milligrams or more of iron a day. Again, heavier menstrual losses, more iron, less menstrual losses, less iron. On average, women eating the average American diet absorb about 2 milligrams of iron a day. So right there, even just with basic facts, most women have precarious iron stores. Heavier losses, less absorption, very easy to see why women can become iron deficient. And if we look at ferritin, average ferritin in women on national studies of healthy women are uniformly markedly decreased. You know, guys, we pile up ferritin, you know, a few college steak and kegers, we're up there, and it stays up until we dwindle off the court. For women, iron deficient start to catch up at menopause, but again, most women are in a state of very low iron stores. And this is kind of the most fascinating study I've ever seen done. In 1967, a group of investigators went to a college campus and did sternal bone marrows on the first 100 women they met. And is the 60s? I don't know. It just, I've always wondered about this. Anyway, but nevertheless, what was very interesting in a healthy, normal population, probably fairly well-to-do, that actually, according to these women, Zippo, were totally iron deficient, no iron stores at all, and another third had decreased iron stores. So 2/3 of these very healthy women were iron deficient, and this is a normal population. So if you only say, oh, we're only going to call the lowest 2.5 standard deviations iron deficient, you're really going to miss out on a lot of iron deficiency. So I think the purpose of this part of the talk was that iron is good. Iron is required by every tissue, and that laboratory ranges of normal in most laboratories don't really reflect physiology. We're actually discovering that good iron stores are important for a whole lot of other things beyond just building up the blood. So how do we diagnose iron deficiency anemia? And for years, we've been taught all the classic tests, the mean corpuscular volume, serum iron, TIBC, saturation. What's the word? Well, it turns out most of these tests are pretty worthless. The classic tests work for classic patients, although it's probably patients you can just look at and figure out they're iron deficient. And the problem is concurrent illness, concurrent sickness affects the labs. So for example, serum iron varies wildly. I took my Fred Flintstone vitamin this morning. My serum iron is very high. Conversely, if I measured serum iron after I did my long run on Sunday, it'd be very low. The MCV, although I'm a big fan of microcytosis, lacks sensitivity and specificity. Again, a lot of things make people, four things in particular, make people microcytic. On the other hand, a lot of competing illnesses, liver disease, can, even in severe iron deficiency, mask microcytosis. The RDW I don't particularly like because I've found it totally and completely worthless over the years. I weep at the amount of trees that have been cut down so we can print this on lab reports. It tends not to be very helpful. Iron saturation is an interesting history. Clem Finch, the master of iron deficiency, many years ago published an article that said low iron saturations diagnostic of iron deficient erythropoiesis. So it's been repeated ever since, low saturations are diagnostic of iron deficiency. The problem is nobody read Clem Finch's paper. Clem called both iron deficiency and anemia chronic disease iron deficient erythropoiesis because both of these you deny iron to developing red cell. And so the classic saturation in anemia chronic disease is depressed. So I like iron saturations to screen for hemochromatosis. I don't do it much for screening for iron deficiency. So the one test that's key is the serum ferritin. Often doesn't get a lot of respect. You know, sort of like the Rodney Dangerfield of laboratory tests. Ferritin. But you need iron to make ferritin. At a molecular level, you actually need iron to generate the ferritin protein. So if the cell does not have iron, it's not going to make ferritin. So if you're iron deficient, you can have tuberculosis, rheumatoid arthritis, and be on fire, plus reading a bad novel, and your ferritin will not go above 100 because your body simply cannot make it. So it is an acute phase reactant, but only in the presence of cellular iron. That's why it's a great test. Again, the ferritin's not perfect, but it is the most accurate, non-invasive test of iron stores that we have. And again, classic study by Clem Finch. If you look at iron deficiency inflammation, iron deficiency and liver disease, the ferritin never goes above 100. Again, if you're iron replete, it's off to the races with ferritin, but it doesn't matter. You're only doing it to diagnose iron deficiency. So again, it's not a perfect test, but right now it's the best test we have of iron deficiency. So rules of thumb I tend to use is pretty much over 100 rules out iron deficiency. The issue is the lower limit changes with age and condition. So for example, several studies have shown that patients over the age of 65 with ferritins under 50, all of them were iron deficient, just no questions asked. And kind of the rule of thumb I use is your ferritin should be higher than your age. It's, you know, if somebody's 80, their ferritin should be 82. Now I always get some smart aleck that goes, well, what if your patient's 106, their ferritin's 104? It's over 100, and I'm just like, go away. Anyway, it's a rule of thumb. Just don't bother me with that. But in general, you know, there is some wobble room. But again, if I see a 30-year-old patient with a ferritin of 30, and I'm seeing her because I'm also asked to give her rituximab for her out-of-control rheumatoid arthritis or other rheumatologic disease, to me, that's iron deficiency. And again, age is important because ferritin naturally rises as you get older in both men and in postmenopausal women. Now, the best study ever done on this was a guy named Gordon Guyette in 1992, took all the studies, and there's really been none since then, on iron deficiency. He agreed that ferritin was the only blood test to order. He noted many years ago the laboratory cutoff were not optimal. Now, this is the 90s. Likelihood ratios were really big, like bell bottoms and disco or whatever. And the idea was that you were more likely than not to be iron deficient until your ferritin was over 40. And if you had some sort of inflammatory state, you were more likely than not to be iron deficient until your ferritin was under 70. And again, he validated this idea that ferritins over 100 ruled out iron deficiency. So I think the key with the ferritin is it's not perfect. But number one, ignore your laboratory reference ranges. If you want a specific number, under 15 is 100% specific. Over 100 rules out. Now, I'll talk a little bit more about ferritins working up people, but again, especially in men, if they're older and their ferritin's under 100, you know, unless they've been like a chronic blood donor or something, that's abnormal. And remember that low ferritins, especially if people are symptomatic, can be a sign of iron deficiency, and they will improve with treatment. Now, what about athletes? Everybody agrees in athletes the numbers need to be a little bit different. All agree ferritins under 20 are iron deficient. The literature is actually pretty impressive. It even goes up to 60. My personal cutoff, again, consistent with the randomized trials, is 50. If people are telling me my running's not as good, I'm off my game there. Or people have said very low ferritins or low saturations. But again, just this idea that, again, especially in somebody very athletic, the ranges of normal won't really help us there. Now, the other test I don't want to ignore is just not doing any test. If I see a young teenage woman who's got a mild microcytic anemia, dollars to coconuts, it's going to be iron deficiency. Why spend the money on the test? Give some iron pills, see somebody back in a month, do a CBC. If it's normal, you made the diagnosis. So again, if you really are pretty sure, why waste the money on testing? And I think we often just don't do a trial of oral iron enough. Now, again, it's affected by inflammation. So if I see somebody with rheumatoid arthritis, they get iron, they get steroids, I have no idea what made their blood better. But again, I think if you got a high pretest probability, it's iron deficiency, that is the way to go. Now, the other thing we sometimes do is bone marrow test. Sort of the gold standard. If you really want to know somebody's iron storage, you do a bone marrow. Problem is, number one, it's still an invasive procedure. I mean, it's a piece, it's a metal, big needle stuck in your hind end. Secondly, it's a little bit expensive. Think for a second how much a bone marrow costs. If you send somebody for a bone marrow, what's their charge? Well, it's very interesting. I recently sent somebody I actually knew for a bone marrow test, and they got a bill for $13,000. So this is a very expensive test nowadays with all the studies people insist on doing them. So I've not done a bone marrow test for iron deficiency in years. You can usually figure it out otherwise. But if you wonder anymore why sometimes you get funny looks when you want bone marrows for things, it's a really expensive test these days. But you get pretty picture. So this is bone marrow with good iron storage, Prussian blue stain. This is the iron developing red cells. Iron deficiency, no iron. Anemia chronic disease, you see robust iron stores, but you don't see it being delivered to the developing red cell. So really the bottom line is the ferritin's the best test. It's the only one down in iron deficiency, only one down in iron deficiency anemia chronic disease. Serum iron's down in both. MCV may not helpful. The total iron binding capacity is very specific, but it's not sensitive. If somebody has a bad night's sleep, their TIBC goes down. So it really loses sensitivity. And ferritin's the way to go. So again, I just said the same thing about 5 times. Go with the ferritin. Now, this is why I like the internet, is you find things like that. How do you replete iron? Well, in this, if you want your children to be healthy and strong, give them iron bitters. What kid's going to eat something named iron bitters? Timmy, here's your iron bitters. Your cockroach cluster is next. And then secondly, what kid dresses like this anymore? Looks like he was going to grow up to be a drug rep or something. So anyway, we tend not to use iron bitters as much anymore for iron deficiency. But I spend a lot of time actually counseling people on iron, how to take iron, what to do. And there's tricks I've learned along the way. Number one, with diet, heme iron is 10 times better absorbed than non-heme iron. We haven't identified these, but there's very specific receptors in the body to absorb iron out of meat in the form of heme, and this is very effective. Interestingly, meat protein also improve iron absorption. So if you just give somebody an iron pill and grind up some meat protein, take the iron out of it, just the meat protein, it improves the iron absorption. So this is a study of giving cheese, egg, milk protein with iron, no improvement in absorption. However, beef, pork, lamb, liver, even a bit with fish, if you mix with iron, the iron absorption doubled. So when I tell my patients to take iron pills, I tell them to take it, if they're meat eaters, with meat. It will double the absorption of iron. In fact, I've always thought about inventing an iron pill wrapped in bacon. I was going to call it iron in a blanket. And I've copyrighted that, by the way. And I haven't gotten that off the market yet. But this is a simple trick you can use to help improve iron absorption. Now, calcium fiber can block iron absorption. Everybody worries, I can't take my iron with cheese, I can't take it with milk. This is actually neutralized by vitamin C. So the virtue of vitamin C is you neutralize calcium, fiber, and other things, and it improves iron absorption. So that's why I'm a big fan of vitamin C with iron, because if I'm telling my patients to take it with food, give vitamin C, so you block those inhibitory effects of calcium, fiber, everything else. Tea dramatically inhibits iron absorption, 70 to 85%. The phenols and some tannins in tea dramatically inhibit iron absorption. So don't swallow your iron pill with tea, and don't take iron for about 4 hours after taking tea. In fact, I prescribe tea a lot to my iron overloaded patients. What's interesting, coffee probably has the same effect. It's not nearly been as studied. I don't know if like Starbucks has suppressed this literature or what, but the only study ever done was a 5-ounce cup of coffee. And I don't know if people remember these. I remember these old vending machines that used to give this really weak coffee. You know, you'd be up in the dorm at 3 in the morning, get terrible coffee, but decreased by 60%. I have no idea what these grande venti things will do to iron absorption. So again, it's often not practical advice that's going to be followed in Portland, but I also recommend staying away from coffee with iron. So I often tell people to take their iron with the evening meal. Steak, great source of iron. Chicken. Bread has iron in it, but remember it's inorganic iron. If you really ever get bored, take a piece of bread, damp it, and then keep it out for a few days, and you actually start to see rust spots from the iron particles in it. A particular tragedy is spinach is a terrible source of iron. People worship spinach. I have people drinking spinach smoothies, which personally I think is an abomination, but try to get iron. And spinach is a particular tragedy for 2 reasons. One, the thinking is that when the data on spinach was originally published, that they actually misstated the amount of iron in it. They misplaced the decimal point, so it sounded like 10 times more than usual. Secondly, spinach and stuff has a lot of oxalates, and this inhibits iron absorption. So spinach actually stinks as a source of iron. So does this mean Popeye was wrong? Well, it actually is not, and this is why I always tell my students, residents, and fellows, you've got to go back to the primary literature on things. And actually, Popeye, if you go back to the original literature, does not eat spinach for its iron. But he actually eats spinach because it's full of vitamin A, and that's what makes a human strong and healthy. So even Popeye knew spinach was a terrible source of iron. He did it for the vitamin A. This must have been olive oil before or gastric bypass, but but the virtue of the primary literature. So what do I tell my patients about dietary advice? I tell them if feasible, increase meat in the diet. Again, a lot of patients, for a lot of reasons, don't eat meat. Try not to drink tea or coffee with the meat, and vitamin C will inhibit iron absorption. Now, what about oral iron pills? Hepcidin returns. The gut can only absorb a limited amount of iron every day, and this maxes out at 10 milligrams. So if you give somebody 1, 3, 10 pills a day, it doesn't improve their iron absorption. Guy named Cosby, long time ago, demonstrated this. Now, on the first day, you got great absorption of iron. The second day and afterwards, it was blocked. And he called this the iron blockade. And actually, your body can only absorb a limited amount of iron per day. In fact, there's work now doing every other day iron, every third day iron, and actually the absorption's the same. So you really can't push iron absorption. Why is this? You take the iron, so let's say I took an iron pill this morning, my hepcidin goes up, and the next few iron pills I take, your enterocytes, you're blocked from absorbing it because hepcidin's up. So it turns out that actually, physiologically, there's no reason to take more than 1 iron pill a day because those extra iron pills are not going to be absorbed. And there's a wonderful, very underrated study, wonderful study showing in older patients, randomized to 15, 50, and 150 TID iron, there's absolutely no difference in the recovery of the ferritin, that a low-dose iron pill once a day was just as good as very aggressive iron therapy, except that the only thing they saw in the higher iron group was a higher instance of gut aches, constipation. So a little goes a long way, and this data has actually been replicated in pregnant women. So a little iron goes a long way. The other question I always get asked is, what is the best iron pill? There's a lot of pills on the market. There's a lot of proprietary pills. What is the best iron pill I should be taking? That's the one the patient can take. So studies have shown there's no consistent difference in any brand or any formulation. One big issue I see is people cannot tolerate iron on an empty stomach. Take it with food. Again, especially if it's a meaty meal, perfect. Once a day with food, they'll tolerate it. So what I tell my patients is the cheapest iron fill. Ferrous sulfate. It's 62 milligrams of elemental iron. They can't tolerate it. Ferrous gluconate, about 30 milligrams of elemental iron. Can't tolerate that. There's a variety of proprietary things with 15 to 25. Take it once a day with meals, with vitamin C, no tea or coffee. Again, intolerant of ferrous sulfate, gluconate, intolerant of that, lower doses. And usually a lot of people, if you're not slamming the iron, if you give it with food, can tolerate oral iron. Now, about this time, somebody always stands up and says, Tom, you're really wrong. The MKSAP totally disagrees with you. I hate to say this, MKSAP is wrong on both accounts. The literature clearly shows low-dose iron is good, and we give vitamin C because it aids absorption in real-life patients. If we had perfect stomachs, we took iron on empty perfect stomach, we wouldn't need vitamin C, but that's not how we're using vitamin C. It's helping us improve absorption for patients who take their iron with food. So what should we see? How should people respond with oral iron? Well, if they're anemic, their hemoglobin should rise by 1 gram in 2 weeks. If it doesn't do it, that's a predictor of iron not rising. Now, if I'm solely treating ferritins, I usually check in a month. My arbitrary rule is the ferritin should go up by 20 in 1 month. So those are the standards I use to assess response to oral iron. Now, a big question is, what iron stores are ferritin replete? You know, what ferritin should you aim for? And that's hard to know. It's very interestingly, physiologically, our gut only goes back to baseline iron absorption at a ferritin over 60. So it seems like our body iron stat is set at 60. We know falling from 70 to 35, there's muscle loss of iron. Sometimes we even see alopecia, restless legs under 100. Personally, I aim to get people's ferritins over 50. If I'm treating restless legs, if it's alopecia, I will aim for over 100. It's been very interesting, especially in the large bariatric population I take care of now, that a lot of people will know when their ferritin's low. Doctor, my hair is falling out again, I'm tired again, I'm itching again, I see some people itch, and I also use that as a marker. Now, all iron deficiency has a cause. We have no physiologic way of getting rid of iron, and it always has to be assumed to be blood loss. And what are contributors to iron deficiency? Well, big one's non-steroidal anti-inflammatory agents. And I have quite a few patients who need to be on iron and Plavix, need to be on aspirin and Plavix, need to be on non-steroidals. They have a lot of issues. And they don't have ulcers or anything. It just seems to be chronic GI damage. We always worry about cancers. This was a study of older patients out of Britain. Angiodysplasia, esophagitis, hiatal hernias causing ulcerations, Cameron ulcers, I've seen quite a bit. Obviously, menstruation's a huge cause. Celiac disease, again, gluten intolerance in Portland is maybe about 80%, but celiac disease is common. Bariatric surgery is a major cause. With most forms of bariatric surgery, you see impairment of iron absorption. Really, at the major procedures like the Roux-en-Y, it just abolishes iron absorption, and this is a very increasing thing we are seeing. So again, sometimes with history, but a lot of times we send people for GI workup. So one thing I always wrestle is, when do I send people to gastroenterologists? Certainly, if they're men, I don't have an obvious cause of their iron deficiency, I send. Older people, you got to worry about cancer. Younger people, you got to worry about other malformations. Women, kind of the arbitrary cutoffs, a little wobbly there. Any woman over 40, if I see somebody's 42 who's had a documented history of very heavy periods, I'll tend not to. Or women with GI symptoms. And again, you always remember the rare cases. But, my course record, unfortunately, for diagnosing colon cancer is age 22. So you always got to keep that in the back of your mind. So what about parenteral iron therapy? When do I go and use IV iron? And this is coming back into vogue, and I use it for several situations. One, I use it in patients that are refractory to oral iron. Even with tender loving care, even with taking iron, their ferritin doesn't go up. And we see that. Some patients, despite what you do, cannot tolerate oral iron. So that's another indication for iron. Sometimes they just can't keep up with the blood loss. Again, bariatric surgery, they get it both ways. You can't absorb it, especially if Roux-en-Y's, there's increased blood loss. Inflammatory bowel disease is another classic situation. Ongoing GI blood loss, you can't keep up. the inflammation, they can't absorb the ferritin, and there's data, at least from rats, that if you take iron, it worsens the inflammation. And angiodysplasia, chronic GI bleeding. I see all these patients like they get transfused for AVMs. Just give them iron. You'll make them transfusion independent. Now, there's a lot of irons on the market. There's iron dextran, iron sucrose, iron gluconate, iron ferromoxetol, ferric carboxyl maltase. The problem is if we just ground up iron and gave it to people, that's very toxic. So we have to wrap the iron in some chemical shield like glucose, gluconate, dextrans and stuff to give it to people. So right now there's a slew of iron preparations on the market. So how do we dose them? Iron dextran is very convenient dosing. Abundant literature, and something we've been doing for the past 3 years, is simply given a gram over 1 hour. Boom, you're done. Longer infusions take longer. Venofer is limited because it disassociates from the sucrose, so you can only give 200 to 300 milligrams a day. So if you want to load somebody, it's several visits. Ferrocet is the same deal. Ferraheme, Injectafer is particularly frustrating. In Europe, it's dosed at 1,000 milligram vials. In the United States, they're only 750, so you really have to replete somebody. So again, IV iron has a variety of different dosing. Now, the big issue that's always dogged IV iron is safety. And the original IV iron on the market was high molecular weight iron dextran, which was very, very toxic. It's not on the market anymore. Minor infusion reactions are very common. And the key is these are infusion reactions. They're not anaphylaxis. So like when the rheumatologists give rituximab, we give IVIG, you can see reactions. That's what you see. True anaphylaxis is very rare. And in fact, the most recent data on death rates from anaphylaxis are all very low, like Infeds 1 in 100,000, Ferrocet 6, Venofer 6, Infeds 3. This is actually much less than we see with penicillin. So if you're comfortable giving your patient penicillin, you should be comfortable giving them IV iron because the risks are actually less with the IV iron. So what are the predictors to reactions? Again, these seem to be non-specific reactions. So obviously somebody's reacted to iron, use different iron preparation. And those patients that come on Epic and, the yellow screen says 58 more under drug allergies. People who react to multiple drugs also will react to iron. So those are sort of my red flags. What approach do I use? Any iron preparation is good. Again, we tend to use Infed. I just tend to give a 1,000 milligram dose. There is some very fancy formula for figuring out iron deficits. This tends not to be that reliable. If people have been allergic before, and more often in pediatrics, I give Venofer. I think the other trick is you got to be aggressive. I see patients like, oh, they failed IV iron. No, you failed to give the patient enough IV iron. Some people do have fairly large deficits. They need 3,000 to 4,000 milligrams of iron. The other thing, especially in people with chronic blood loss and with bariatric surgery, is after I give them iron, I follow the ferritin every 3 to 4 months, and the second it falls under 50, I redose them. You don't want your patient symptomatic again. You want to prevent symptomatology. And I have quite a few patients with AVMs, chronic GI bleeds, that actually are getting maintenance iron every 2 to 3 months to keep it up. So the key is not only to replete, but to follow up the patient and see they don't need to be repleted again. So what are the trends in iron deficiency? Iron deficiency is going up. It's because there's overall been a tremendous reduction in meat intake, our greatest source of iron. Secondly, everybody's on PPI or H2 blocker, and that blocks iron absorption. Now, it's almost like if you have stomach acid now, it's un-American. And that's another reason why we're seeing this. Thirdly, bariatric procedures are going up tremendously. As the data comes in about the benefits of bariatric surgery, more and more patients are getting it. And even with relatively simple procedures, we're seeing inability to absorb iron. So iron deficiency is definitely going up. And severe iron deficiency, or need to give parenteral iron, is definitely going up. Secondly, we're understanding variability in iron absorption. So it turns out iron absorption is not yes or no. It's a Gaussian distribution. I'll see women in clinic for a history of heavy periods. They're having periods 15 days out of the month. Their CBCs are normal. I see other women, can't absorb iron, normal periods, very iron deficient. And it turns out there's a protein called TMPRSS SS6 that's a key enzyme in iron deficiency, that there's actually multiple polymorphisms in the population. and that actually some of these predict for lack of iron absorption. So we're understanding that probably some people do not absorb iron very well. Again, we always assume blood loss. We need to always rule out blood loss, but remember with not, some people may simply not absorb iron. So what was the point of my talk today? You're probably asking yourself. So number one, iron is good. I tried to make the case that even non-anemic iron deficiency has a variety of bad effects. Secondly, ferritins over 50 are good. We know under 50 is associated with fatigue, impaired athletic performance. Oral iron is good, but give it as 1 pill a day, give it vitamin C, give it the meal, especially a meaty meal if they're willing to do it. And if people truly cannot respond to iron, there is a role for IV iron. I want to thank everybody for inviting me, and I'll be glad to field any questions. Great, great. Any questions? Yes?
I occasionally donate blood. I barely get home for my donation. The Red Cross is on the line again, ask me to schedule my next one. Maybe I want to give 2 units next time. Does this lead to decreased mental function or decreased athletic prowess?
Oh, no, people around here are shaking their head yes. No, I'm just kidding. Yeah, so the question is, donating iron. That's an issue actually we run into a lot, is donating iron, donating blood. So certainly becoming severely iron deficient may, and I actually, for my patients who donate blood, I frequently will check ferritins. And actually some Red Cross programs actually will put their women and male donors on iron supplementation just to prevent this. So I think it may be good to get the ferritin checked, because again, being otherwise extremely healthy, you can drop your ferritin to really low levels before the Red Cross starts turning you down. So, it's also amazed me, again, like any other laboratory test. I've seen people with ferritins of 3, they're running marathons, people with ferritins of 18, they're in bed. There's a lot of individual variability. But, I also donate blood and I run, so that's actually, I follow my ferritin too. Plus, it's really bad if somebody discovered my ferritin was 35, so I got to keep it up. Yes?
Hi, Tom. Is hepcidin made because it's synthesized in the liver, which prompts me to ask, A, is it synthesized in the liver? And B, what about our cirrhotics? They tend to develop varices, they bleed intermittently, et cetera, et cetera.
Those are both good questions. So hepcidin is made in the liver, so that's partly where the name comes from. And it's actually very interesting. It's actually a very tight protein ball, sort of related to, I think, oval albumin, some other, these proteins called defensins. So it may have been played also, it may have had an antimicrobial role at one time. And then secondly, iron metabolism in people with liver disease is really interesting. They really become iron deficient. I'm unaware of any hepcidin studies. I imagine it's 0. And one of the things we see a lot is iron deficiency. So I'll see these patients for liver transplant or their workup, and I have a few patients with liver disease on chronic iron. They lose it due to varices. A lot of people will get this portal hypertension gastropathy. They lose it. So I'd say the majority, except for the ones obviously hemochromatosis, the majority of patients I see with liver disease are iron deficient, and that may well be playing a role too, that they can't absorb it and they have increased losses.
Tom, have there been studies in vegetarians, prevalence of iron deficiency, and should vegetarians be taking an iron supplement?
So if you look at vegetarians and the prevalence of iron deficiency, it is increased. It's a risk factor, and especially being looked at athletes, it seems to double the risk of being iron deficient. There are ways of supplementing iron for vegetarians. Beans and legumes are a very rich source of iron. It may not work for your social skills, but a very legume-rich diet can help. Blackstrap molasses, I think it's horrible, but that's a very rich source of iron. So there are ways that you look on the internet of finding that. I do for my women, especially women athletes who are iron deficient, we do recommend supplementation. The other interesting thing about women and athletic performance is right now the leading sponsors of very good research is the US military, because there is a series of studies that show when women go to boot camp, their ferritins just hit bottom. And now there's actually MREs, ready-made rations, that are supplemented with iron for women warriors to keep up their iron store. So it's actually been interesting now that most of the literature comes from this. But I think definitely vegetarian, especially athletic ones, I think iron supplements would be okay. Yes?
Back to the liver question, it would seem that if you have liver disease, you can't make enough hepcidin, which should improve your iron absorption. Mm-hmm. So maybe it's really blood loss that's the issue.
Yeah, so it's probably just mainly blood loss. I think it's ulcers, blood loss, gastropathy that does it. Yes, no.
What about too much iron in men? And, it's been said that there's more cancer,
Yeah.
more all-cause mortality.
Yeah, so I think that's one thing that's really dogged the literature is this idea that, well, higher iron stores are correlated with cancer, heart disease, all sorts of bad things. Part of the issue, I think, has been twofold. One is iron stores are measured by ferritin, but we know heart disease is an inflammatory disease, maybe getting cancer and that. So is the ferritin there just being acute phase reactive? Is it higher? Secondly, what makes iron stores go up? Well, if you spend your life eating big T-bone steaks, is that what puts you at heart disease? And it's been convoluted. There's been some studies that say if you actually look at iron intake, especially in women, there may be an opposite relationship that, again, women's a little bit different matter because of iron losses, that that actually it may make you more prone. So I've not put that much credence on that idea. What's interesting is that if you have normal iron genetics, you can't really build up that much iron with oral iron. Your body just stops absorbing it. And interestingly, the only patients we see ever overdose on oral iron are genetic carriers of hemochromatosis and other iron metabolism things. So I personally don't worry too much about overdosing on iron or that. And again, I think a lot of that literature has confounders in it. Although I always joke if I ever became dictator, I'd make everybody have a ferritin of 85. But
That's your main goal here?
that's right. That's going to be, yes. That and get the key to the Bob Dylan archives in Oklahoma.